acute ischemic stroke patients, mechanical thrombectomy has become the standard of care. And fortunately, mechanical thrombectomy actually has developed to the point that we can see a very high rate of recanalization or opening occluded blood vessels after the thrombectomy. And in fact, those rates are somewhere between 80 to 90%. But if you look at the clinical outcome, there is a mismatch. Still, somewhere between 40 and 50% of the patients experience death or disability even after successful thrombectomy. So the question is that what is the reason for this mismatch? And it seems that yes, there is an occlusion in one of the larger blood vessels to the brain, but there is actually another set of changes that actually happen at smaller blood vessels in the brain that are past the site of the occlusion. So even if you open the occlusion, those secondary changes remain and prevent adequate blood flow from reaching the brain tissue and still leading to infarction and ischemic stroke and subsequently leading to death or disability. So these devices cannot do anything for the smaller blood vessels that are past the initial site of occlusion. So intra-arterial thrombolysis has been around for almost 40 years, but never in this has not been tested in this particular context. And essentially, the premise is that once you open a blood vessel, you have the secondary occlusions, secondary lack of blood flow into these blood vessels that are small and supplying distal parts of the brain. And you can actually use the same catheter you used to do the thrombectomy and inject these intra-arterial thrombolytics at the site of the occlusion. And the thrombolytics will actually dissolve some of these microclots and microthrombi and some of the secondary lack of blood flow into the smaller blood vessels and actually improve the blood flow to the brain that's still ischemic and actually subsequently reduce the rate of death or disability. Now, the clinical trials actually have shown encouraging results, but sometimes conflicting results. So, really, one, the trials have been including a small number of patients, so you really cannot tell conclusively whether the intra-arterial thrombolysis was actually beneficial or not. Most of the time, it's actually giving a suggestion, yes, it was beneficial. So essentially, people have done is try to combine these together. And essentially, if you try to combine all of these trials together in form of meta-analysis, one thing is clear: there's a suggestion of benefit. All of the trials are showing that there is a suggestion of a benefit. What we don't know is what particular patient population benefits the most. What is the actual risk in various patient populations after thrombectomy when we give them intra-arterial thrombolysis? What is the right medication to give in intra-arterial thrombolysis? Is it alteplase? Is it tenecteplase? And one trial actually used pyrokinase. So I think that there is a lot of unanswered question, but nonetheless, I think that we cannot ignore that intra-arterial thrombolysis after thrombectomy can offer potential for recovery for patients, can improve the outcomes of patients, and clearly needs to be addressed in a conclusive randomized clinical trial so that we can incorporate it in our practices, appropriate in the right format, so we can make the most difference in reducing death and disability in patients with ischemic stroke.